Hi everybody. To close out our day, I'd like to introduce chiropractic neurologist Dr. Aaron MacArthur. He's the owner and medical director of Portland Chiropractic Neurology, the owner of New England Hyperbarics and Portland Physical Therapy, and the upcoming president of the Maine Chiropractic Association. Dr. MacArthur completed his undergraduate degree at the University of Maine at Orono and went on to complete his doctorate in chiropractic at Parker Chiropractic College in 2007. He has completed a postdoctorate with the American Chiropractic Neurology Board and 2 fellowships in mild traumatic brain injuries and vestibular conditions. Most recently, he has completed an extensive course in Dysautonomia diagnosis and treatment. Dr. MacArthur's practice revolves around treating difficult neurological cases through retraining the brain and body through neuroplasticity. Please join me in welcoming Dr. Aaron MacArthur.
Thank you. How was that? Is that too loud? Great introduction, thank you. It's pretty cool. Oh well, let's just get to it. I was going to draw some stuff out for you guys, but now I'm just going to have to explain it. So, sorry about that. Cool. Anyone here familiar with our practice? Yes. And yes. Can we speak about that? Yeah. So Courtney is currently a patient at our office. How are things going?
Good. Good.
Yeah, you just started, right?
Yep.
Yeah. But have you noticed any changes yet?
I think so. Yeah, and the migraines come down.
Good.
But
Nice.
good time of year between seasons to be on the mend also.
Yeah. Yeah, awesome. And Courtney, just started with us. I mean, I think you've been coming in for like a week or two. 2.5 weeks. You're doing hyperbaric too, right? Yeah. So, the one thing, key aspect at our clinic is that we do a very multi-modal approach to things, very comprehensive style of treatment. I am a chiropractor, so sometimes that's a little confusing because they say, okay, what adjustment do you do for the brain? I say, I don't. Chiropractic is just a part of what I do. Really, you might call me you would call me a functional neurologist that is also a chiropractor. The functional neurology work is separate from chiropractic. We call it a chiropractic neurologist, but they're really 2 different things. The reason chiropractic is so helpful in functional neurology is that we're not just a brain, we're also a body too, and these things are interconnected. So it's really nice when, my expertise started in the body, much like you guys, and then I postdoctorally gravitated into working with the brain. And when I was in school, I got really interested in neurology just because it was offered. And I was like, well, I got into chiropractic because it's dealing with the nervous system. I was like, why would I stop at the body and when I have this whole brain that controls everything? So I decided to pursue that. I started when I was in school at this different program, so I was kind of doing 2 things at once, but it was great because when it came to neurology, courses, I didn't have to study, so that's the one positive for that. Cool, so we'll be here for hopefully just an hour for you. You guys have been here all day, so I'm trying to make this stuff interesting. Let's just watch this video real quick. As chiropractic neurologists, our goal is to retrain the problematic areas of your brain and nervous system. Let's do that again. I like it, but it's not that good. Somebody no, that wasn't. Oh, there you are. Go ahead. Thanks, man. All right, let's try that again. That's just to follow the logo that we created that I like. All right, so functional neurology. Before we play that video, or do you want me to play it to see if it's good?
Yeah, but you can try.
Okay. As chiropractic, our goal is to reach
those systems interact with your body.
So,
Many patients we see have been to other doctors who have cleared them of pathology or more serious illness, but continue to experience debilitating symptoms despite drugs and surgical treatment. If this is the case, you are likely experiencing a functional neurological disorder, which means that the neural pathways in your brain that communicate important information to other parts of the brain and body have been interrupted. This interruption of communication slows information processing and results in symptoms. Many patients that seek our neurological care are experiencing complex migraines, post-concussion syndrome, dizziness, lightheadedness, positional vertigo, and brain fog. Visual symptoms are also common and include blurred vision, eye movement errors, reading strain, nystagmus, difficulty riding in a vehicle, and focus and attention issues. Patients also report symptoms of numbness and tingling, tremors, abnormal movements, and gait imbalance issues. Our chiropractic neurologists have extensive postdoctoral training in general neurology and specifically in the areas of vestibular, migraine, dysautonomia, musculoskeletal, pain conditions, and post-concussion syndrome. A key component of our treatment is that we find the source of your functional neurological condition by utilizing advanced testing to find the specific areas involved in your brain dysfunction. This includes a thorough clinical exam, tilt table test, balance test, and video nystagmography, which uses eye movements to measure brain function. Treatment consists of specific neurological exercises that are designed to retrain pathways and communication in your brain that result in more improved signaling and processing, eliminating your symptoms.
Awesome. Okay, so that's just like a little video that does an overview. But, you know, so we're here for concussions. We're talking about concussions, and this is a major thing that you guys are dealing with on a daily basis, probably at work, depending on, I guess, what, you know, field you're working in. But, you know, what's the what are we looking for, right? We're looking for concussions. We're looking for things that are lasting a little bit longer than they should, right? And we're looking at things that are functional based. So anything that's not picked up by an MRI or CT scan or something like that still has to be fixed, right? And so we have a lot of these conditions that come in, like concussions are one of them. Of course, that's what we're talking about here today. But these things that come in that we're saying, well, they couldn't find anything. So they said, go sleep it off, or, you know, stop doing what you're doing and give it a couple weeks, and, you know, and then they come back and they say, you know, actually you kind of got worse. You know, now I've got brain fog, now I've got worse headaches, now I can't really, you know, track a ball, you know, or I can't, you know, I can't read very well, I'm getting dizzy and lightheaded, I'm actually getting dizzy when I stand, and, you know, just all kinds of things. But also feel free to ask questions at any time, just interrupt me and raise your hand, whatever. And so what we look at is, we look at these patients and we say, you know, medical neurologists really aren't treating them. They're just, I'm in Portland, obviously, they don't even take these patients because there's nothing they can do, because there's no medication to create neuroplasticity, there's no medication for a concussion, there's a few medications for headaches and migraines, obviously, but aside from that, what do? Well, that's when we have to look at things from a little different perspective. We have to look at them functionally. Functionally really means, how is the brain working? How well is it working, and how well is it connected? And so in concussions, one of the main things that happens is that we have disruption in these connections in our brain. And these connections, called synapses, bundle together to create what we call neural pathways that connect different regions of our brain together, and they connect our brain also to our body. And so if these are disrupted for any reason, then we're gonna have symptoms, okay? Think of these things as just roads in the brain that are carrying information from one area to another. And you can have the best packing plant up here, but if it doesn't get to the location in a timely manner, then it doesn't matter, right? It doesn't matter how well this is doing if it's not getting here. And so one of the major issues with concussions is that it's the disruptions in these pathways that occurs. and that's what creates the majority of symptoms. Yes, we injure the brain. Yeah, the brain is injured in general. Our gray matter is more external in our brain, and the rest of it is white matter. White matter, as you probably recall or already know, are the connections. They're the things that carry the signals. The gray matter are the cells or the neurons, okay? And so when we injure our brain, it heals. And just like a bruise, think about it like a bruise on your arm or something. You're gonna see it for a few days, it's gonna hurt for a few days. And after a while, the inflammation that presented itself to help heal is gone, right? And so then we say, okay, when my arm heals after a bruise, it goes back to normal. When the brain heals after it's been bruised, it doesn't always go back to normal, because these pathways are these neural pathways that are connecting these parts of the brain. If they're not stimulated, they become weaker. And what happens sometimes is that if the brain is inflamed long enough, and it may not come back to its normal state. And then, we're kind of doing the whole presentation. This is a good intro, I hope. When we can't get those connections from one place to another because we have damage to those synapses or those neural pathways, or they just became weaker, then we reroute the information. Think about this like your GPS in your car, and you have to be here at exactly 3 to give this presentation, and if if there's a big backup traffic, or the bridge is out, or something to this effect, and you're late, because it reroutes you, but you're 20 minutes late. And it's like, sorry, we all went home, So that's what happens in the brain, is that the information is too slow, and it gets there too late, and that's what creates these symptoms. That's brain fog, that's slow processing, that's oculomotor tracking errors, that's convergence issues, that's pupillary, people talk about light and sound sensitivity. What is that? Or light sensitivity. Well, you can't constrict your pupils well enough, because your sympathetic system is in overdrive, which dilates your pupils, so you can't constrict against that. Okay? So that's just an aside, but it's very important, because when you look at these people, these are the main symptoms you're seeing: dizziness, lightheadedness, headaches, brain fog, dysautonomia, which they're not saying, but dizziness when they stand up, all these different types of things that are really, really the foundation of what happens with a concussion. And the post-concussion syndrome, the research, you'll see one research study that says 30% of people have post-concussion syndrome, and you'll see one that says 15, one says 25, one says 20. I will tell you that probably most people have it to some degree, and they just kind of compensate, and work their way around it. It's not until you feel better that you're like, wow, I didn't realize how much I was compensating. Sometimes we'll throw people in the deep hyperbaric chambers, pure oxygen deep hyperbaric chambers will do 20 or 30. Here's an example, me doing hyperbaric, right? So I started doing the deep hyperbaric, and I had concussions and played sports, and a couple of bad concussions. And I've done like 20 of these sessions, I'm gonna try to get to 40 to 60. But I'm like, man, I had no idea how crappy I was feeling until I started feeling better. And I was like, dang, what's this like for I know this for other people, but I'm on the other side of the table usually. So it's very interesting, because people, I get a lot of patients that are chronic post-concussion syndrome. They've had this for years, 6 months, 2 years, 5 years, 20 years sometimes. People come in and they're like, I don't know if you can do anything, but this is what's going on. And so we look at it and we say, yeah, we often can, and we just have to figure out where those pathways are originally disrupted, and then as we retrain those over time, it's going to take a little longer the longer you've had it, those rerouted pathways start to disappear. It's called synaptic pruning, or synaptic arborization. So pathways that are not needed, if you don't use it, you lose it. Well, the brain wants to do the right thing for you, but if it can't do it, it has to find another way. But if you can teach it to go back and do the right thing again, those alternate pathways become less useful. So the brain says, you know what, we're just going to cleave them off. Kind of like, you know, a macrophage eats a bacteria or something to that effect. And this is also the way that your therapy works, right? For like emotional type talk therapy and these types of things. You're taking old pathways in your brain where you routed the way that you perceive the world or experiences you've had, trauma and all these different things that create pathways in your brain a certain way that says, yes, you know, every time a dog, you know, barks, it scares me because it's attacked by a dog when I was little or something. And so you have these pathways that built up to say, alert, alert, alert when this happens. And they're not the normal pathways in your brain, they're rerouted pathways. So they create this alert type of scenario. That's the sympathetic nervous system. You get nervous, you get anxious, your whole body is in a state of like either freeze or fight or flight, right? Both are really fight or flight, but one is inaction, one is action. And this happens in the brain, right? After concussions, most of, you know, a lot of the things that happen in the brain are disruption in these different pathways that then results in just this sympathetic barrage of like over sympathetic activity, which is vasoconstrictive. So now you're not getting good blood flow to the brain potentially, or often, and now you're creating new symptoms as time goes on because of all these other changes that are occurring. It gets worse, or it can get worse. So, okay, let's just slow it down for a second and go to the next thing. So, we talked about this. So I'm a concept guy, right? I don't really want you to memorize stuff today, not that it's 3 o'clock and, you know, you've had a long day of great presenters. I really like that last lady that presented. That was helpful for me too. That's why I want to stop. So we have a lot of neurons, right? We have 100 billion neurons. We're actually born with the same amount. Well, we're going to lose a few, but you know, we generally have the same amount as we do as adults as we do as babies. I'm like, well, that doesn't make sense because we're so much smarter as adults. We say, yeah, absolutely, that's correct, because it's the connections that you make between those, or these synapses or these neural pathways that create that are learning, that create intelligence, that create movement, that create all of these things. I mean, the brain, one of the main reasons the brain exists is for us to move in an upright position, and the body fuels the brain. So like, you know, what you guys do as athletic trainers is extremely important. It's neurology, right? Because these things are super connected and they don't exist without the other. And that's why when we look at, you know, what makes a good functional neurologist, that, you know, we have medical doctors that are functional neurologists, we have chiropractors, we have, you know, DOs, you know, sometimes optometrists occasionally, stuff like that. But, you know, people who understand how these things interact. And, you know, when you're exercising, you're moving, you probably heard that you can create more, actually create more neurons in the hippocampus through exercise. That's one of the only ways that we know how we can create new neurons, actual brain cells. Otherwise, we say we can't create new brain cells. We create new connections, though. And these connections are what make us super healthy. The more connections we have in our brain, the healthier we are. Asterisk, obviously those alternate pathways don't really fit into that model of an explanation, but just pretend. And all of this is called neuroplasticity. So this whole term is called neuroplasticity. So how we create these new connections, the creation in the formation of new neurons, or the reconfiguration of synapses and all these different things is called neuroplasticity. We're forming new pathways, we're creating a new habit or a new way of doing something. A lot of these things become habits. You get into really become very efficient over time doing things the wrong way sometimes. And that's not good. And that's where people come in with these types of things. That this is why it takes a little bit of time to treat people, because it's not like plug and play. You know, you can't just you know, do it once and expect it to change. Thank God the brain doesn't work like that. Because if that was the case, that I ask myself this a lot, and this is the answer to come up with, is that we would be changing all the time so much, we would be crazy. You know, yes, we can change very quickly. That does happen because to create neuroplasticity, it occurs temporally or spatially. Temporally means we do the same thing over and over and over again until it changes. That is fine to do. That's a good way to create neuroplasticity. The other way is spatially, which is lots of different things saying the same message that create change. Okay? And what I like to do is I like to combine those things in my office. You say, okay, let's create the best opportunity to make neuroplasticity. So we do things from a very comprehensive model where we do things with eye movements and tilt table and trigeminal nerve stimulation, vestibular rehab, and some chiropractic care and PT and all these different types of things in hyperbaric oxygen therapy. Because oxygen, if you remember in your electron transport chain, because you never thought you'd use this again, that makes energy. Okay, so we need oxygen as the final electron acceptor that creates either 38 ATP or if you don't have it, 2. And that's the lactic acid buildup, right? So that whole thing is just oxygen. And you know, that last presenter talked about the importance of getting to these things quickly. And that's a major part of it, right? Is to just keep that blood flow to the brain going. And this person's gonna have long-term damage, not only of their heart, which we need to perfuse tissue blood to that, but to their brain. My understanding of one of the things with CPR is that you're their heart, right? So you just keep it beating, in a sense by the compressions. That might be the wrong way to say it, but you know, that's kind of how I think about it, because the more oxygen the brain has, generally the healthier it is. I mean, there's always oxygen toxicity, and there's seizure activity and these types of things, but generally speaking, we want really good oxygen. So we want really good posture. So we have a lot of athletic trainers in here who are, you know, athletic and probably previous athletes and all these types of things with good posture and all these aspects, and that's going to allow you to breathe better. And that's going to get more oxygen to your brain. And that's super, super important. Okay. So, we get that inflammatory response. We kind of talked about this. We have damage to these axonal connections in the brain. So, when you have a concussion, you're not just damaging the gray matter or the cells. We talked about this, but we're actually tractioning a lot of these long white matter tracks. Think of these things like, you know, like a rubber band. Actually, when we were in college, in grad school, the spinal cord, like an actual human spinal cord, like it's rubbery. Feels like a big, thick rubber band. It's kind of interesting. But when you have a concussion, you actually traction your brain stem, because your brain stem and your spinal cord are fixed in your spine and up through, you know, your skull, but the brain moves around a little bit. And so what happens is it moves around a little bit, and if it's fast enough, you know, it can traction these really quickly, and it can create actual damage or break these connections. It doesn't break all of them, but it'd be like, probably be akin to, you know, working out or strain, I should say, of a muscle, right? You tear some fibers, and as long as it's, you know, not greater than 50% or so, you're probably okay. You can rehab that. You guys maybe think about it differently, or love to know that. But, you know, or let's say it's 20-30%. It heals, hopefully with the right care, but in the brain, it may heal too, but it might not. It just doesn't, if you don't use that pathway enough, it's like a muscle, but it's not like a muscle. You know, it's like fibers, but it's different. They have to be stimulated, just like a muscle. You know, if you wanna grow your bicep, you know, you don't do leg extensions. Asterisk, we know that legs help everything else, but you know, so you have to be really specific in the brain when you're addressing these pathways You can't just do a protocol. You can't just go in there and do brain. Okay, when you come in, we didn't hand you an iPad and say, do luminosity, for an hour, and you should be fine. We go in and we do this long, extensive exam, and you do the VNG, you do the CAPS, you do the tilt table, testing, and we say, okay, all of this together, we can see where the problems are in the brain, and now what we're doing is we're just kind of like, kind of reconnecting them. We use some things like nerve stimulators and those types of things, but we're not really doing that. What we're doing is we're just stimulating. We know what those parts of the brain do, and so we can then utilize that as part of our treatment. If we have I don't remember exactly which I will share anyway, but let's say like someone has a left frontal lobe that is damaged in their concussion, and that pathway is related to the left mesencephalon, the upper part of the brainstem, and the right lower, and also the right lower brainstem because it crosses over in the right cerebellum, the right vestibular system, the right vestibulospinal pathways, and so the right side of the body. So we say, okay, like we know where these things are, so we can use specific types of treatment to address these areas. And so if it's left frontal lobe, we can say, well, we really want to do rightward saccades. We want to do these quick eye movements where you look from one target to the next, only to the right side, because that left area, the left frontal lobe, saccades to the right. And we may do that upwards, because that corresponds to the mesencephalon properly. So that's going to stimulate that part of the pathway. We may do cerebellar activities on the right side only. We can do vestibular rehab on the right side only. We're going to do trigeminal nerve stimulation on the right side only. We're going to do maybe an adjustment of the ribs and the neck when we get to it. We haven't done anything with the neck. We don't really do much with the neck because it's we will eventually, potentially, if we need to, but we really focus on breathing. We really focus on thoracic and breathing aspects to really get this foundation of function back. Then we might go in there and just tweak a little bit up here or do, wherever it needs it. But when you get the brain and the systems working well, then you go in and you just tweak these things a little bit. They don't take much. It's really nice because the brain's mapping is restored. The connectivity is restored. Its pathway is accepting information really well. It's kind of like talking to somebody who doesn't want to hear what you have to say. Say the best things in the world, they don't want to hear it, right? And so the brain, if it's affected and damaged, and then you go in there and you blast it with a cervical adjustment, and it doesn't really do much in that sense because it doesn't have any place to land, right? So you say, well, I thought you were a chiropractor, don't you do this stuff? I was like, yeah, we do, absolutely do this stuff. And cervical adjustments are extremely helpful when in the right sequence of things. And so it's really important to look at these types of patients and help the individual, like you guys, you're fine would be fine for that. But when you have somebody who's neurologically compromised, you don't want to necessarily go in there and make the system work harder than it needs to because it's kind of hanging on by a thread as it is. So we don't want to do that type of stuff just at that point. What's going on there?
Cells that we have as adults, approximately 100 billion. But what allows the brain to learn, grow, and heal are the connections that form between these cells. If communication is disrupted for any reason, symptoms may occur as our ability to process information.
Yeah, so just a little visual. That's kind of how it works, but it's just a concept. So that's pretty cool. Any questions so far?
Hi.
Yes.
How do you attribute what you're explaining, what you're doing to act like the clinicians in this room probably know more than me, I'm just a student, but how would you actually implement what you're talking about on the field in a training room, especially for a athlete who can't necessarily afford to go to?
Absolutely. That would be our next seminar. Yeah, because that's a little different length of conversation. So you'd have to know a lot about what different things do, and so we could teach some of these things, like how to do this stuff, but it's not as simple as, oh, if you see this, do this. it's a little bit complex. Now, that being said, I think there are ways to do this. So that's a great question, but not today, unfortunately, buddy. Next time. I would love to do that, honestly. That would be really fun. I don't think we have enough time. So here, you know, a lot of the common concussion symptoms, you know, most people come to see me for dizziness, and vertigo, and the headaches, and brain fog, and blurred vision, and then we get sensitive to light, and then we get into, oh yeah, well also I have orthostatic intolerance, you know, my heart rate increases. They don't really usually say that. They just say, you know, I stand up, I get head pressure and dizzy. And then what we see, fatigue is a big one. And then we ask a few more questions. I'm like, yeah, is it really hard for you to be in like a busy environment with a lot of optic, well, I don't say optic flow, but a lot of things moving around you? Like, yes, absolutely, that's really hard. That's optic flow, their brain visual connectivity, you know, is slowed, so their eyes can't really keep up with what's called the optokinetic stimulation around them. So this stimulation of people moving, their visual system can't keep up with it because their brain is slow. So when you see people, if you see a lot of visual symptoms of people and eye tracking issues and these types of things, and we'll try to go over a couple things, you know, at the end, see if we can talk just about a few of the things you can look for, because that is important. But if there's a lot of optic flow going on around these patients, they're not going to do very well. It's not really it's not nothing wrong with their eyes themselves. It's the brain connectivity to the visual system, right? So what we see sometimes is, you know, people come to see us who maybe, you know, somebody's kind of done some generic just to go to rehab, and that didn't really do the whole thing because the pathway was maybe more specific, needed to be addressed a little more specifically. And then we go and figure where that is, and then we reconnect the strength of communication between the brain and the visual system, which is these neural pathways, and then the person can then handle really busy, you know, stimulus. They can saccade, they can pursue targets well, they can converge properly, their pupils respond appropriately, this accommodation reflex, so they can do all these things in real time. Like if you can picture, you can see what's actually happening in like a really good athlete. You know, what's happening is they're processing and they're predicting and they're tracking and they're converging and they're constricting their pupils at just so fast. Like maybe like, you know, the difference between like a Major League Baseball player and like a, you know, college baseball player, you know, might be like the, you know, whatever, like a hundredth of a second, but it's all the difference, right, between hitting that, you know, 98 mile an hour fastball or seeing it, you know, coming in as a changeup or whatever it might be. And so then, you know, that's really important for them. For most people out in the world, what's important to them is you get them from like this really crappy scenario to just being able to handle life so they can play with their kids or grandkids or, you know, go to the store, you know, those types of things. So, which we can really easily do. It's just a matter of locating where the problem is and going from there. So this is the compensatory response. We talked about rerouting the GPS.
Stressors around us. Because of communication errors in the brain, we often form secondary compensatory pathways in an effort to help maintain signaling, but this requires a lot of energy, and these paths are inefficient and can create symptoms. In addition, other regions of the brain upregulate their function to help, but this causes imbalances. These imbalances between underactive and overactive areas of the brain are a major contributor to symptoms. A lot of energy is required to maintain these compensations, which is borrowed from our limited supply. So higher brain functions like memory, focus, motivation, sleep, and emotional regulation that require a lot of energy suffer. Brain communication cannot be observed on most MRI, CT, and other medical tests, but functional neurologists are able to use specialized neurological testing that allows them to locate the particular neural pathways that are the source of your symptoms. The eyes are the window into the brain. And although functional neurologists use many tests to determine what is causing your symptoms, eye movement testing is a major part of their diagnosis. Each eye movement is directly connected to a specific part of your brain, allowing us to locate the source of your symptoms. Once the root cause is determined, a treatment plan is made to strengthen the weaker neural pathways and remove compensating ones.
Yeah, so hopefully that visual helps a little bit, but that's what we're doing. So, you know, what I didn't talk about was the way that this is very interesting about the brain is that if one area isn't working well, something else will work harder. But you see this in the body, right? If you're, you know, have weak lower trap in scapular stability, guess what's going to take over? You know, these other things are going to take over, and you're going to, you know, it's going to rise up, right? Because these things that are now, you know, they didn't do anything differently. They're just no longer inhibited. They're no longer opposed, so that the shoulder blade rises, you get this internal rotation, and we start to get neck pain creeping up. We start to get headaches. We start to get these other aspects. We may have a rotator cuff injury in the future because you don't have very good stability of the scapula. So, you know, as the chiropractic part of my brain loves shoulder blade stability. Shoulder blade stability is like one of the most wonderful things you can do for someone's posture and someone's like overall upper torso area, in my opinion. And so I love giving people exercises for that. You know, you say, what does that have to do with brain? It has everything to do with brain. Because the shoulder has this major neural pathway called the rubrospinal pathway that is this big red nucleus, it's called, up in the contralateral mesencephalon, the top part of the brainstem, that feeds tons of information to the basal ganglia and therefore the rest of the brain. So having good shoulder mobility is really important for your brain. In fact, one of the exercises that we often do with people, same thing with the hip. One of the exercises we do with people is this complex type of movement activity that really stimulates the cerebellum really well and increases its output to the brainstem, which then saturates the rest of the brain with stimulation. And so it's really, really cool. So you really want your big proximal joints to be healthy and strong. How are we doing on time, Paul?
You're good.
Good. Cool. So the name of my presentation, right, has to do with this vestibular. It's vestibulo-ocular, it's vestibulo-autonomic, it's proprioceptive. So I wish I could draw this because it's really helpful. So the vestibular system is often really impacted with concussions because this labyrinthine system, the actual inner ear organ, is very peripheral. It's the most peripheral part of our brain, besides our visual system. But when we have injury, concussions, we often, you know, injure this area a little bit, inflame it. And what happens is that disrupts the messaging in towards the brainstem. Anybody know what the nerve that comes from the inner ear to the brainstem is? Students? Vestibulocochlear nerve. Okay, it's cranial nerve 8, and so it carries auditory and balance information in. So your vestibular system is potentially, this is a little, it's opinion based in a lot of information, but my opinion would be that with concussions, the vestibular system is the major system often involved. And the vestibular system, as it comes into that brainstem about halfway up, okay, into the palms. Yeah, you can see it there, yep. So it goes up to the eyes, it goes down to the autonomic nervous system, which lives in the lower part of your brainstem, and it goes down through the vestibulospinal pathways to control a ton of your body, muscle, tone, actions, coordination, all of those types of things. So it's really, really important, and it comes into this area called the vestibular nuclei. And think about it just like a four-way intersection. And it's going up, it's going down, it's going across. It's really, really important. So like we said before, the inner ear, when the inner ear becomes affected for a length of time, that pathway slowed down. The vestibular nuclei that process this information in the brainstem, they started to slow down too. They got weaker. So then all of a sudden, the inflammation's gone, things kind of go back to normal, but the person doesn't go back to normal. Because the changes that were made in the brainstem, and therefore the rest of the architecture, microarchitecture of the brain, they shifted, and they didn't shift back. And they don't quite know how to get back to normal. So we have to then go in and look at what is the actual vestibular neural pathways affected, and we have to reset them, retrain them, stimulate them. You know, all of these things are doing the same thing, but recalibrating the system. And then when you do that, what happens is you start to improve autonomic nervous system function, because this is super connected with the autonomic nervous system. Because so everybody has about 5 to 6 liters of blood in them. This might be the next slide too. Here we go. So everybody has about 5 to 6 liters of blood in them, but it's not enough to be everywhere at once. So we have to have a system that's really, really fine-tuned to be able to push blood where we need it, when we need it. And so if we don't have oxygen, it doesn't matter, I don't care how many brain cells you have and how many connections you have in those brain cells. If you don't have oxygen to those brain cells, they're not gonna work because they don't have energy. You could have a Ferrari out front, but if you don't have gas in the tank, you're not going anywhere. So it's the same idea. And so when somebody stands up from laying down, or just gets up, or whatever it might be, gravity pulls blood down to the lower extremity, to the splanchnic arteries, to basically your gut, and downwards. It has to push back up to the brain really quickly. It does it in 2 different ways. It has this system called the baroreceptor system that lives in your carotid artery. We talked about the carotids earlier, trying to find them, right? And so it lives in the bifurcation where it splits into your external and internal carotid. They live in this area, these little baroreceptors, they're sensors that respond to stretch. And so when your carotids are stretched, this emits a signal to the brainstem that says, hey, slow down heart rate and blood pressure. And then what happens is that happens, hopefully, and then they relax, and the relaxation sends another signal that says, hey, speed up. And so it does this all day long. But this baroreceptor system is, polysynaptic. It's poorly myelinated. It has a long latency in the brain, meaning it takes it a while to kind of do it. Because it doesn't need to be like super fast. It's just like fast enough. But it's more of like an all-day process. It's just always on. It's consistent. It's reliable. But it's not really meant for speed. It's like consistency. The vestibular system is meant for speed. So the vestibular system's like, I'm gonna do stuff, and I'm gonna do it fast. And the vestibular system has a direct connection to this autonomic nervous system that lives in the lower brainstem. This autonomic nervous system is what controls where blood goes, where we need it, when we need it, right? It lives in the medulla. And so it's getting information from the baroreceptor system, and it's also getting information from the vestibulo-sympathetic reflex pathway. And that's important because when people are laying down, the first thing that fires is the vestibular system, which has a latency of 7 to 15 milliseconds, meaning it turns on really fast, as comparison, your visual system has a latency of about 70 to 80 milliseconds. So it's 10 times faster than your visual system. And you know how fast your visual system is. It's pretty quick. So when you start to stand up, this vestibular system, if it's healthy, sends a signal down your autonomic nervous system that says, hey, prepare, we're moving upwards. It loves to go through the saccule, part of your otolithic vestibular system, that responds to linear acceleration. So as you stand up, this vestibular system fires down and says, prepares everybody. Can you stand up and you're fine? You can jump up and run, and it's no big deal. If that system is slow or it's in error, this is where people have a lot of problems. This is actually where a lot of POTS and any of the dysautonomias come into play, right? Most people say POTS and they think that's not the only dysautonomia, that's just one of them. And sometimes misdiagnosed doesn't matter, but POTS is defined as your blood pressure doesn't change, but your heart rate goes way above 30 beats per minute. What you want to see when someone stands up is you want to see the heart rate go up a little bit and the blood pressure go up a little bit. And that's normal, because that's what it's going to do, is going to push that blood back up to your brain like toothpaste, like the end of the toothpaste. You're trying, you forgot to go to Rite Aid, so you're like, or Walgreens, I guess. So you like push it up and you finally get that little piece, you're like, good, I don't have to go till tomorrow. And that's what happens, except this happens super fast. And then when it gets to the brain, you really want a good relationship between your sympathetic and your parasympathetic, because your parasympathetic then dilates the blood vessels and kind of washes the brain over with rich oxygenated blood, so it can really perform super well. So another thing that is activated is your large hip muscles in your legs. And they're really important because they send a signal up through this cerebellum and through this same pathway that the vestibular system uses. These caudal vestibular nuclei, the lower parts. And so what we do in practice is that we actually, remember the leg? Right. Do you want to do it?
We have a table.
Oh, it's okay. I think maybe we'll do it at the end. So thank you.
Do it, Court.
Yes.
You guys want to see it?
Yes.
Yeah.
Okay. Do you remember which side? I don't remember.
Right side.
Okay. So yeah, you have to go ahead and lay down. So I don't know if you're getting dizzy anymore when you stand up, but
Fully.
you are? Okay, so go ahead and stand up quickly. Dizzy, lightheaded?
Yep.
Okay, good. All right, so let's do this, let's see if it changes. And this isn't something we prepared, so Courtney wouldn't do that to y'all. So we're gonna do this complex movement in our lower extremity. And what I'm doing is I'm stimulating the same pathway, but I'm stimulating it through a different mechanism. It's kind of like, well, I can get in the house through the front door or the back door, it doesn't matter, right? So I'm just gonna get in the house. So I'm gonna get in that pathway and I'm gonna start stimulating that pathway. And it has to be very complex because if it's stiff, then it decreases cerebellum output to the brain instead. We want to increase cerebellum output. We want to increase communication. Okay, now don't embarrass me. Just kidding. All right, go ahead and sit up quickly. Okay, so that's awesome. Thank you for not embarrassing me. That's because we already know which pathways involved. We know all that stuff. And what we did is we stimulated this pathway correctly. And what that did was it gave that autonomic nervous system more information about what was about to happen. So it was able to speed up its transmission. You say, well, is that all you have to do? Unfortunately, no, but it is one of the things we do. And if we do that in combination with lots of other types of treatments, comprehensive, right, spatial, summation, over time, repetitively, with hyperbaric oxygen, we use that, we don't need that, but we like it. It's going to make changes over time until it becomes permanent. So she doesn't have to do that for her whole life. Once we change it back to normal and get rid of those extra pathways, clip off the little tree branches that grow up, right? We don't like those, we want to grow down. And so once we get that remyelinated, or replasticized, I should say, in the direction for that original pathway, then she's good. She's done. Doesn't have to come back. She'll never have another problem for this. She hits her head again, it'll be like she has her first concussion. Versus like when a lot of people come into me and have had multiple concussions, if you rehabilitate the brain and get it back to its neutral kind of position, then that's like the first concussion you've had if you have another one, which is pretty cool. That's not like research, that's clinical understanding. So, I haven't seen that, but that's research, but that's basically what I see with people. Because we see a lot of people that have another concussion or different things, they're like, yeah, this one wasn't as bad. And they're like, I smoked my head. And I'm like, well, is your system's doing better? So it can handle that. Because we do know, we can infer, right? We do know research says, hey, if you're on your menstrual cycle when you have a concussion, it's different. If you're tired, if you're stressed, if you're anxious, if you're whatever, it's different. It affects you differently. It's just like, what's the state of your brain when you go into smacking your head? It affects your long-term, affects it long-term. So, yeah, this is all some stuff that I geek out about, but I don't want you to try to memorize that. But the NTS, the nucleus tractus solitarius, is the main component of your autonomic nervous system. And it fires down to your intermediate lateral system in your spinal cord, which connects to your blood vessels and heart. Something I think that you guys might find interesting is that all skeletal muscle, skeletal blood vessels, they only have sympathetic innervation. They don't have parasympathetic. And so we often think about everything as like sympathetic and parasympathetic. It's not that simple, unfortunately. In the brain, we do a few places. The gut and genitalia basically have both the innervations, but everywhere else in the body is only sympathetic innervation. The reason you see like temperature changes, people are like, I get cold easily, or I can't handle like a hot shower, get lightheaded and dizzy, is because their autonomic system isn't working super well. So that sympathetic innervation to their skeletal blood vessels, where it usually would constrict and pull it away from your skin. When it pulls your blood vessels away from your skin, you're going to conserve heat. When it gets closer to your skin, it gives it off. So disperses it. So your ability to regulate your internal temperature comes from your autonomic nervous system. So you see this complaint with people like long term, where they're just like, they don't have it. We talk about this. One of the ways that I kind of talk about what we do is that we're mapping the brain to the eyes.
Brain communication cannot be observed on most MRI, CT, and other medical tests.
We already did that. All right, so this is some of the. So this is some of the testing that we do. This is the analysis of the test. The test has already been done. So this is a convergence. They're following a thumb in. It should be nice and smooth, but what happens is it's kind of like, you can see it's like choppy. So this is affecting their accommodations, affecting their depth perception. It's affecting how so when your eyes do this, when it's not doing it the way you want it to, then you're going to get this disrupted signal that tells your brain, oh shoot, I'm moving when I shouldn't be. So it sends a signal down to your autonomic system that has a sympathetic response when it shouldn't, and it creates a major disruption for people in their day-to-day blood flow to their brain. And that is where a lot of these symptoms come from. This is, so this is some of the tilt table, which right? So tilt table stimulation, we use a trigeminal nerve to stimulate the brainstem with the tilt table. This is like the gold standard for autonomic stuff. Paul, how are we doing?
Probably about five minutes or so.
Great, I have 40 slides, so. But anyway, we pair a lot of these things together. This is all like beautifully researched. You can see some of I didn't put a lot of research papers on this, even though they're all from that, but I put a little research paper down there. There's this direct trigeminal nerve connection to the lower brain, to the autonomic nervous system, in a lot of places in the brain that, if you like brains, this is like candy. It's just so cool how the trigeminal nerve, how much it interacts with the brain and how it affects neuropeptides, how it affects neuroinflammation, how it stimulates the autonomic system, how it improves cerebral blood flow. And so we pair these things together to retrain this system, this autonomic nervous system. Because even though we talked about the vestibular system being a major connection to it, it's not the only thing. We want to use multiple things. We want to retrain these systems so that they go back to their, maybe even better than before, who knows? But for a lot of people, they're better than they can remember because it hasn't been this good since their first concussion when they were 14, which is cool. Convergence errors, we don't have time for that. Proprioceptive stuff. This is talking, you guys, well, we want to talk about this real quick. So, this is talking about proprioception is the ability for, well, you know what proprioception is.
A balanced spine helps create a balanced brain. When the spine is aligned well and moving properly, it sends constant information to the brain using gravity as its reference. This enables the brain to determine spatial orientation, coordinate movement, process.
And then we get into...
Consider the common misbelief that back or neck pain arises solely from misaligned joints or strained muscles. In truth, these ailments stem from a loss of joint movement, leading to inflammation and nerve irritation, causing pain, numbness, or tingling. This causes muscles to respond by tightening, causing more pain and dysfunction, giving the appearance that they are the cause of the problem. Over time, abnormal patterns develop as we lose vital information from sensors in our joints and muscles.
All right, how's everybody's sound sensitivity? You get any old concussions need to work out? That's pretty loud for me too. So this goes back to the spatial summation, temporal summation. I'm not much of a slide presenter, I'm sorry guys, I just like to talk about stuff, so it's kind of like,
Shouldn't say.
I don't know, anyway.
Concussions cause immediate inflammatory reactions in our brain, as well as damage to the pathways that travel throughout the brain. Just as the brain can change negatively after a concussive injury, we can change it back. By locating the weaker areas of the brain that have occurred after injury, we can design specific targeted exercises to restore strength to these pathways, returning the brain to its normal function. The brain is moldable, like plastic, and changes throughout our lifetime. It especially changes in response to brain injuries, reorganizing its neurological pathways, resulting in abnormal signaling that cause emotional, physical, and cognitive symptoms. There are usually multiple areas involved after concussions. Chiropractic neurologists evaluate and treat all portions involved to restore full function of the brain and reduce concussion symptoms, returning to normal.
It's not everything we do, but that is just a little bit. This is the hyperbaric chamber. We have multiple, but these are the hard chambers. That's part of my practice. It's different practice, but those are amazing for concussions. Amazing for concussions. I love hyperbaric. There's a lot of cool research on it now. There's more and more coming out. Hyperbaric is still very young, but we know how it works. That's the cool thing. When you know how something works, you can infer how to clinically use it if you know what you're doing. And we do, thankfully. We're not going to watch that video, unfortunately. If you go on New England Hyperbaric's website, you can watch this video, or our YouTube page, and all those types of things. I assume all of you will. It's just a convergence spasm. This is something you see a lot after concussion, where the eyes, and they come into a near vergence, they do this little shimmery thing. That does not feel great for headaches and dizziness and all these things. It's a very disrupted system. This same patient had a tremor in the left hand, so that had to do with that right mesencephalic and basoganglionic system. Here's something that's kind of cool. So this is what we look for when we're looking at our testing. We're looking at the eyes drifting in a direction or nystagmus, and that's one way we indicate if the vestibular system's been affected. So you can kind of see these. You probably can't see it, but these angled kind of drifts and stuff through here that we can really we use infrared cameras on these things. We put them in the dark, and you can see what the eyes are doing when you take away fixation. Fixation is super important to take away when you're looking at the eyes. You can do this with an ophthalmoscope, but you gotta have them cover one eye. And when you're looking at an ophthalmoscope, just remember it's the opposite direction of what you're saying, because you're looking at the globe of the eye. You probably already know that, but if we don't, we'll go over that next time. This is optokinetic stimulation. So this is what I was talking about with optic flow. We do this, we activate it, artificially, I guess we use the word artificially. And so what we want to see is like teeth, shark's teeth all the way across, but that doesn't look like that, right? It's kind of flat. If you see one, and then it's very flat. So this person can't handle a busy environment. I automatically know it's gonna suck for them in a grocery store. And then we treat them for a little bit, and then we get it back. And so the eye should be doing that in this case. They should be moving like that. That's an optic nystagmus. That's a normal response. It looks like shark teeth all the way across. So that's really cool. So we like that stuff. And that's that. Questions? Yes?
Well, if the primary symptom was post-concussive brain fog, for example, you have an athlete that presents as she did with the orthostatic issue,
Yeah.
will you get a carryover, meaning if that improves, you'll get a necessary improvement in brain function
Yes.
writ large, and then the brain fog goes away?
Absolutely. Yep, so the brain fog that we see is usually autonomic based. It's just, brain fog is just not enough blood flow to the brain. It's not really neuroinflammation. I mean, that can cause it. I shouldn't say it like that. The majority of the time, it is not enough blood flow to the brain. Either you're not getting it up to it, so the brain can't siphon blood up to it. It has to be pushed. So the sympathetic nervous system is not all bad. We need to have it to push blood, squeeze blood up, or have strong legs. Those help to pump blood up, or a good strong core helps push blood up. All of these things matter. And so pushing blood up, and then when it gets to the brain, it needs to be able to turn off and dilate. And if that system is kind of like cranking, like too sympathetic and not enough parasympathetic, it can't do that process very well. That's exactly what you're describing. So the brain has to improve for that to improve.
Follow-up question.
Yeah, please.
Have you seen in your practice subclinical presentations of these other things? So the kid really didn't have the dizziness or some of the other things,
Yeah.
but yet, and I'm saying this because a lot of you in secondary schools probably have these kids that just don't present necessarily with these neurological things, but there's this
Yeah, they won't be able to.
fogginess to their, like academically, they're
Yeah.
struggling and other stuff. And
Exactly.
you wouldn't necessarily think to refer them to.
That's such a good point, because they can't articulate it. And in fact, a lot of patients can't either. That's why you need to kind of, they're coming in for like, maybe they finally have a headache or migraine or something, but they have all these other things. You test them, and they're like, whoa, or they come in and their eyes are like all over the place. They're like, well, they don't challenge themselves like per se, like, maybe like a D1 athlete would or something, or college or a high school athlete or whatever it might be. But yes, to your point, absolutely. The symptoms may be subtle to them, but their performance is terrible. And you objectively look at all these tests and you're like, whoa, you're walking around like that? Good for you. Your brain must be pretty good. And that does matter how good your brain is. I guarantee you I should have been on things like ADHD, whatever you want to, right? But I wouldn't say you should be on those things. But I could have been. But my brain figured out how to use it for something really good, right? Or so it's like you have people with different types of brains who are somebody has something happen to them and they're can't move, and the other person has the same injury and they're like, yeah, just notice that I don't want to go out as much these days. So anyway, great question, thank you. Yes.
Have you noticed that some of this stuff also affects, if they have a behavioral, increased anxiety or
Oh,
depression?
heck yeah. Yes, great point. Yeah, so absolutely, because these systems, if you need oxygen for your brain to work. And so if you're not getting good oxygen to your brain, you're not getting good because that autonomic system, if you're in a sympathetic fight or flight, you're anxious. Even if your vestibular system is just affected, you get anxiety because your brain wants to know where it is in space. Most of these kids, but all of us adults, kids, when you get a concussion, you lose your spatial orientation sense. And when you lose where things are in relation to the environment around you, it sounds like it's not a big deal. It is everything. It is everything to the brain. The brain wants to know where it is in relation to gravity, graviceptive, meaning we want good proprioception from the spine. This is all the work that you and I do, in our daily work. And it needs to match up with the vestibular and the visual system. And if those things, if they're coming in and one eye is looking one way and this way is looking this way, which we see all the time with our patients because it's just a neurological thing, then their whole system is working super hard to try to like understand where they are in space. They don't have time to love somebody. They don't have time to enjoy their life. They don't have time to not be anxious or all these things. They're putting so much energy into just keeping themselves like from whatever it is, right? And you get rid of those things, all of a sudden their lives come back and they're like, oh man, like, yeah, my relationship was better. You know, I just feel better. I like, you know, you're like, what do you mean you feel better? It's like, I feel better, you know, you like feel. Like I'm just like emotionally, I'm like more relaxed. I went down, I was teaching at college last week in Atlanta, and we treated one of the students there, and he was like, afterwards, you know, he's like, ah. I was like, what's up? You okay? He's like, I'm just too relaxed. He's like, I'm used to being like, you know, and I was like, well, buddy, you might appreciate that after a while, you know, like, and he was kind of joking, but, you know, people are missing out on this stuff. Yes?
Maybe a little bit off topic, but have you
It's all
seen
good.
COVID had any effects on
Oh
these?
my
Or
God,
showing any
thank you.
Long COVID symptoms?
Yes, long COVID is dysautonomia.
Yeah.
So take that to the bank. Clinically, long COVID is dysautonomia. And we fix it the same way we do the concussions, in the sense of like, depending on where the problem is, but it is dysautonomia. It's the brain fog, it's the lethargy, the fatigue, like you just don't want to do anything. You're just not getting good blood flow right. A little different mechanism, of course, of injury, but just same idea. Is that it?
Well,
You look like you had a follow-up.
well,
You were saccading up to the right, so I knew your left brain was curious. So that's
the, like there's a cardiac
What a nerd,
component.
right?
Well, there's like over 200 symptoms of long COVID, but like
Yeah.
the non-nerve, I mean, it's neurological.
You know why there's so many symptoms?
It's neurological.
Because it's neurological, because it's blood flow.
Yeah.
You know, this beautiful big brain up there, but if you don't give it any blood, or enough blood, then you're gonna have a myriad of symptoms. That's the other aspect of concussion and long COVID, right? But of concussion is that a lot of people have multiple symptoms, because there's one or two of these symptoms that are usually affected. The vestibular and the autonomic are like the main ones, and the visual. And they just create this plethora of symptoms, and people think their whole brain's screwed up. It's not. It's just like one system that fuels everything to a degree.
Yeah. So the fatigue that a lot of long COVID patients feel.
Fatigue is oxygen. What do you do when you're running stairs and you have lactic acid, right? That's just oxygen not getting, and you're like, oh, I gotta quit. It's the same thing in your brain. It's like lactic acid. It's not lactic acid, but it's just not enough oxygen to the brain. Yep, just not enough blood flow. And that comes, from that. And that's what we treated a ton with hyperbaric. So there's some cool research that you're seeing about hyperbaric on long COVID, but it's because it's, getting oxygen and healing the brain and healing these autonomic areas. We're doing the same thing with the, functional neurology rehab too. From day one, I was like, okay, this is dysautonomia stuff, so we're gonna treat it like this. I did like a 2-year dysautonomia program that was just amazing. It changed, revolutionized the way we look at some things, Yes, please.
Quick question.
Yeah.
Not necessarily one, someone that has DVT, can you treat them?
Deep vein thrombosis. Yeah, with hyperbaric.
Yeah, can you treat them?
Yeah, so I haven't yet. Yes, you can, but I have to look into that one. Like, I have to, before I answer you too much. I've been studying hyperbaric for a few years now. I work with a medical doctor who's like a consultant. Whenever I get like a curveball question, like that was not a curveball, but like a question I'm like, I think so, but I want to double check. There's only really a few contraindications to it. That's not one of them. Hyperbaric doesn't create like, stroke and stuff like that. So you can like move these things around. It's just improving circulation. But yeah, good question. I think so, but if you do have a patient that you're curious about, follow up with me and we can absolutely like check on that for you.
There's potentially DVTs being on the rise from COVID, so.
Oh, yeah, yeah.
It's like one of the topics.
I haven't heard any contraindications about that at all, but again, I like to double check. If I don't know something, I want to know. I'm going to find out. Yes.
So, Go ahead, one
Also,
last
I can-
question, one
also,
last
I can
question, and
hang
then
out
we'll take it
afterwards If you
aside.
have questions and you wanna come ask me personally, I'm in no rush, but I understand you guys
Go
gotta
ahead,
get
one last,
into it.
one last.
I think Andy Galpin does a podcast on it, but have you seen anything with creatine in concussion prevention and accelerating rehab?
Yeah, so, we actually used to do that. I don't do it much anymore, because we have so many other tools to kind of work with it. But yeah, the creatine, it provides extra energy for the brain. Yeah, I remember one of my professors used to use it. He would have them, kids especially, like, take some creatine and go run around the, parking lot a little bit, come inside and then treat them. Yeah, I'll get you afterwards.
So